Let's talk about Propofol, the white milky syringe that every anesthesia provider recognizes instantly. It's one of the most commonly used intravenous anesthetic agents in modern medicine. From routine inductions to total intravenous anesthesia, Propofol has transformed how we practice anesthesia. But beyond its familiar appearance lies one of the most elegant pharmacologic agents in our specialty. So let's break down everything you need to know. Chemistry and formulation. Propofol is an alkyl phenol derivative, chemically known as 2,6-diisopropylphenol. It is not water-soluble. It is highly lipophilic. And that lipophilicity is the reason it works so fast. It penetrates the brain almost instantly. Because it cannot be dissolved in water, Propofol is formulated as a 1% lipid emulsion. The concentration? 10 milligrams per milliliter. The emulsion contains 10% soybean oil, egg phosphatide, which is lecithin, as the emulsifying agent, and glycerol. Two things to know about this formulation that boards love to test. First, the lipid emulsion supports bacterial growth, specifically E. coli and Pseudomonas aeruginosa. This is not a theoretical concern. Propofol-related infection outbreaks have occurred in clinical settings due to poor aseptic technique. The rules? Strict aseptic technique when handling Propofol. Draw it up immediately before use. Discard open syringes within the recommended time limits. Never leave an open syringe sitting on the anesthesia cart. Second, long infusions increase plasma triglycerides. The lipid vehicle accumulates. This is clinically relevant in prolonged ICU sedation and is one of the contributing factors to Propofol infusion syndrome, which we will get to. Mechanism of action. Propofol is a positive allosteric modulator of the GABA-A receptor. Let's break that down. GABA-A is your brain's primary inhibitory receptor. When GABA binds to it, chloride ions flow into the neuron. The neuron becomes harder to fire. Inhibition occurs. Propofol enhances this process. It does not mimic GABA directly, it modulates the receptor, making it more sensitive to GABA's effect. Specifically, Propofol prolongs GABA-mediated chloride channel opening, increasing chloride conductance, hyperpolarizing the postsynaptic neuron. More inhibition, more hyperpolarization, across billions of neurons simultaneously. The net effect? Consciousness disappears in approximately 30 seconds. Propofol also has minor activity at glycine receptors, but this is not the primary mechanism, and it is far less important clinically. What Propofol gives you, hypnosis, amnesia, sedation, and anticonvulsant activity. What Propofol does not give you, analgesia. Zero. None. This is one of the most tested facts about Propofol. If you are doing a painful procedure, you must add an opioid. Propofol alone will not cover surgical pain. Induction. For induction of general anesthesia, the standard adult dose, 1.5 to 2.5 milligrams per kilogram IV. Loss of consciousness within 30 seconds. Recovery is rapid, not because Propofol is metabolized quickly initially, but because of redistribution. After the bolus, Propofol rapidly redistributes from the brain into peripheral tissues, primarily fat and muscle. The concentration in the brain falls as the drug leaves for the peripheral compartment. The patient wakes up. This redistribution phenomenon is why Propofol provides such clean, rapid emergence compared to many other agents. Pharmacokinetics. Distribution. Propofol is highly lipophilic. Rapid brain uptake, short effect site equilibration. The drug gets to where it needs to go quickly. Primary metabolism, glucuronidation. This is a phase 2 reaction, not CYP mediated. Metabolites, glucuronide and sulfate conjugates, excreted in the urine. Key point, the metabolites are inactive. They do not contribute to clinical effect. Clearance. Here is where Propofol becomes genuinely interesting. Propofol's clearance exceeds hepatic blood flow. This should be impossible if the liver were the only site of metabolism. But propofol undergoes significant extrahepatic clearance in the lungs and in the kidneys. This is why liver disease does not significantly impair propofol clearance. A patient with cirrhosis, propofol clearance is largely preserved. You do not need to dramatically adjust the dose for liver disease. Renal disease. The metabolites are renally excreted, but the metabolites are inactive. So renal failure does not require dose adjustment either. The drug itself is cleared via extrahepatic routes. Half-times. Elimination half-life, 0.5 to 1.5 hours. But the clinically relevant number is the context-sensitive half-time, which remains less than 40 minutes after infusions of up to approximately 8 hours. This is what makes propofol so useful for TIVA, total intravenous anesthesia, even in long cases. Emergence remains relatively predictable and rapid. Age effects. Children require higher induction doses than adults, larger volume of distribution, higher clearance. Do not make the mistake of underdosing children with propofol. Elderly, the opposite. Reduce the induction dose by 25 to 50%. Smaller volume of distribution, lower clearance. Increased pharmacodynamic sensitivity. The same plasma concentration produces a greater effect in an elderly patient. The classic board pitfall, giving a standard adult dose to an elderly patient and watching their blood pressure fall off a cliff. Sedation. For procedural sedation or monitored anesthesia care, typical infusion rates, 25 to 100 micrograms per kilogram per minute. The advantages of propofol for sedation. It is easily titratable. You can turn it up or down and the effect changes quickly. Rapid awakening. When you stop the infusion, the patient wakes up cleanly. Low incidence of postoperative nausea and vomiting. One of the reasons propofol is preferred over benzodiazepines for many sedation procedures. Maintenance of general anesthesia. For maintenance as part of TIVA, typical infusion rates, 100 to 300 micrograms per kilogram per minute, usually combined with an opioid for analgesia. Because remember, propofol provides none, and sometimes with other adjuncts, dexmedetomidine, ketamine for analgesia, lidocaine infusions. CNS effects. Propofol has profound and favorable effects on the central nervous system, and this is why it is one of the preferred agents in neuroanesthesia. It decreases cerebral metabolic rate for oxygen, CMRO2, dramatically. It decreases cerebral blood flow. Secondary to the reduction in CMRO2, flow follows metabolism. It decreases intracranial pressure, ICP. What it preserves, cerebral autoregulation, the brain's ability to maintain constant blood flow across a range of perfusion pressures, remains intact with propofol. CO2 reactivity also preserved. At high doses, propofol can produce burst suppression on the EEG, a state of deeply suppressed brain activity, useful in refractory intracranial hypertension management. Propofol is excellent for awake craniotomy. You can achieve a comfortable, cooperative patient at appropriate propofol doses, while the neurosurgeon maps eloquent cortex. It is an anticonvulsant, useful for status epilepticus and for electroconvulsive therapy, where it shortens seizure duration for improved patient comfort. One important caveat: high doses that cause hypotension can lower cerebral perfusion pressure, MAP minus ICP. If propofol drops the MAP significantly and ICP is already elevated, CPP may fall to dangerous levels. Use propofol thoughtfully in the patient with elevated intracranial pressure. Cardiovascular effects. Propofol's most clinically significant limitation is cardiovascular, and it will humble you if you are not paying attention. It decreases systemic vascular resistance via vasodilation, the dominant mechanism. It decreases mean arterial pressure. It decreases preload. It decreases afterload. And it produces mild negative inotropy. The mechanisms: propofol inhibits sympathetic vasoconstrictor activity, reducing the neural tone that maintains SVR. It also decreases intracellular calcium availability in vascular smooth muscle, contributing to vasodilation. The patients most susceptible to propofol-induced hypotension, hypovolemic patients who have no reserve in their preload, elderly patients who have reduced cardiovascular reserve and increased pharmacodynamic sensitivity, patients with poor left ventricular function who are dependent on elevated sympathetic tone to maintain cardiac output. Push propofol in these patients without phenylephrine at the ready, and you will have a problem within 60 seconds. Heart rate, usually unchanged or mildly decreased, but propofol can cause significant bradycardia. In rare cases, severe bradycardia, or even asystole. The mechanism: propofol blunts the baroreflex. When blood pressure falls, the normal reflex is a compensatory tachycardia. Propofol attenuates this reflex, relative parasympathetic predominance, and heart rate may actually fall at the same time blood pressure is falling, a double hit. For treatment of propofol-induced severe bradycardia, beta agonists like isoproterenol may be more effective than atropine in severe cases because the mechanism involves blunted sympathetic reflexes rather than pure vagal excess. ECG. Propofol does not prolong the QTc. It is acceptable to use in patients with Wolff-Parkinson-White syndrome. Respiratory effects. Propofol causes dose-dependent respiratory depression. At induction doses, apnea is common. You will see it almost every time. The mechanisms: decreased tidal volume, decreased respiratory rate, decreased CO2 response. The central chemoreceptor drive to ventilate is blunted. Decreased hypoxic ventilatory response. The peripheral chemoreceptor hypoxic drive is also suppressed. What is preserved? Hypoxic pulmonary vasoconstriction. This is important. Propofol does not impair HPV the way volatile agents do. In thoracic anesthesia during one lung ventilation, propofol preserves HPV, minimizing shunting, maintaining better oxygenation than volatile agents in some studies. Airway advantages. Propofol is actually favorable for airway management. It causes less wheezing than thiopental, the old barbiturate induction agent. It produces bronchodilation. It blunts airway reflexes, reducing laryngospasm risk during intubation and extubation. One exception: formulations containing metabisulfite as a preservative may cause bronchoconstriction in asthmatic patients. Know which formulation you are using. Antiemetic effects. This is one of propofol's greatest clinical advantages. Propofol significantly reduces post-operative nausea and vomiting. It is better than volatile anesthetic-based anesthesia for post-operative nausea and vomiting prevention. In some studies, it is more effective than ondansetron for maintenance anesthesia. Small doses, 10 to 15 milligrams IV, can actually treat established post-operative nausea and vomiting in the recovery room. The mechanism of this antiemetic effect is not fully understood, but it is clinically real and clinically valuable. Antipruritic, a less commonly known but clinically useful property. Small doses of propofol, 10 milligrams IV, can treat neuraxial opioid-induced pruritus and cholestatic pruritus. Useful to know when a patient is climbing out of their skin from neuraxial morphine. Intraocular pressure. Propofol significantly decreases IOP. It is an excellent choice for open globe injuries, where even a brief spike in intraocular pressure could cause extrusion of vitreous, and ocular surgery in general. Excitatory phenomena. Propofol can produce excitatory movements, myoclonus, random jerking, opisthotonus in rare cases, during induction. These look alarming, but are usually not true cortical seizures. They are subcortical phenomena, disinhibition of subcortical motor pathways. not epileptiform activity on EEG. Do not panic, but do document them. Propofol infusion syndrome, PRIS. This is the most feared complication of propofol, and it is board critical. PRIS is a rare but potentially fatal syndrome associated with prolonged high-dose propofol infusions. Lactic acidosis, propofol infusion syndrome, has been described in pediatric and adult patients receiving prolonged high-dose infusions of propofol, over 75 micrograms per kilogram per minute, for longer than 24 hours. Critical illness. Children particularly vulnerable. Catecholamines and steroids are co-risk factors. The pathophysiology, impaired mitochondrial function, disruption of the mitochondrial electron transport chain, failure of beta oxidation of fatty acids, cellular energy crisis. The classic findings, metabolic acidosis, rhabdomyolysis, hyperkalemia, cardiac failure, bradycardia, renal failure, lipemia. The clinical picture, a critically ill ICU patient on high-dose propofol sedation who develops an unexplained metabolic acidosis, rising lactate, increasing cardiac dysfunction, and elevated CK. Think PRIS. Management. Stop propofol immediately. Supportive care. ECMO if cardiac failure is refractory. Monitor triglycerides and CK during prolonged propofol infusions. Other adverse effects. Pain on injection, the most common adverse effect of propofol overall. Patients describe it as burning or stinging along the vein during induction. Prevention strategies. Inject into a large vein. Pre-treat with lidocaine, or add lidocaine directly to the propofol syringe. Green urine. Propofol can cause the urine to turn green. This looks alarming. It is benign. It occurs because propofol metabolites are excreted renally and can give the urine a green discoloration. Hypertriglyceridemia, from the lipid vehicle, relevant in long infusions. Infection risk, from the lipid emulsions supporting bacterial growth, hence strict aseptic technique. Rare pulmonary embolism from lipid coalescence, extremely rare, but documented. Hallucinations and dreams during emergence. Patients sometimes report vivid and sometimes sexual dreams after propofol. Document appropriately. Potential for abuse. Propofol has been misused as a recreational drug. Miscellaneous. Propofol does not trigger malignant hyperthermia. Safe in MH-susceptible patients. Safe in acute porphyria, unlike many other induction agents. Propofol is a potent antioxidant, structurally similar to vitamin E, reduces lipid peroxidation. This may contribute to some of its organ protective properties. Decreases the stress response to surgery. Your top 20 exam pearls. Before we close, the 20 things you should have memorized. 1. Positive allosteric modulator of GABA-A. 2. No analgesic properties. None. 3. Onset within 30 seconds. 4. Induction dose 1.5 to 2.5 milligrams per kilogram on healthy adults. 5. Rapid emergence via redistribution. 6. Primary metabolism glucuronidation. 7. Clearance exceeds hepatic blood flow. Extrahepatic clearance occurs. 8. Cirrhosis does not significantly impair clearance. 9. Renal failure does not require dose adjustment. 10. Children need higher doses. 11. Elderly need lower doses. 12. Decreases CMRO2, cerebral blood flow, and ICP. 13. Preserves CO2 reactivity and cerebral autoregulation. 14. Causes hypotension via vasodilation and mild myocardial depression. 15. In rare cases, it can cause profound bradycardia or asystole via blunted baroreflex. 16. Causes dose-dependent respiratory depression and apnea. 17. Excellent antiemetic. Reduces post-operative nausea and vomiting. 18. Pain on injection is the most common adverse effect. 19. Propofol infusion syndrome. Metabolic acidosis plus rhabdomyolysis plus cardiac failure. Stop propofol immediately. 20. Does not trigger malignant hyperthermia. Safe in MH. 20 items, 1 drug. One of the most important drugs in anesthesia pharmacology. No propofol cold. It will show up on your exams, and it will show up in your clinical practice every single day. I'm Anesthesia Buddy. Stay sharp. See you in the next one.